My name is Lynda Stack, and I work at the STAR Clinic, which is a clinic associated with Housing for Health. And I've been there for about a year and a half now, started when the clinic opened. And pretty much my entire NP career has been working with underserved populations, with one little detour when I worked at a ski resort community for about 5 years. Definitely different crowd, but learned a lot about orthopedics and suturing people up because they were always banging themselves up. So it was kind of fun, but I much prefer this work, definitely. But before I get into this whole presentation, I just want you to know from a provider perspective, and especially working with you in this program, that in this last year and a half, I think the key to the success and why we've been so successful is your role. Your role for me is the key role in keeping people in housing, keeping them safe, keeping them healthy. It's been a really interesting experience to see. You know, our target population is the really sick, the sickest of the sick, the ones that keep going into the ER, and their chronic illnesses are not managed whatsoever, and they're really on a path, a very progressive path toward, you know, an end game, okay? So when they are connected with ICMS and they get their case manager, it's amazing. It's like it stops them in the progression of that disease process getting to a very bad state. So I can, you know, so talking to you today is a gift for me, because I just think you guys are amazing and what you do is miraculous. So just keep up the good work, and I just love working with you. And also, and I put this out there is, you know, it doesn't matter if you have a patient that's not our patient at the STAR Clinic or whatever. If you are coming up to, you know, a brick wall on something, whether it's getting your patient, you know, a wheelchair or medications or an appointment or whatever, send me an email. I have my cards here. Just send me an email. Let me know. I can help troubleshoot it for you, okay? So with that, let me start this presentation. So we're going to talk about sort of the three top most, you know, frequent medical conditions that we see in our clients, okay? Hepatitis C, diabetes, and congestive heart failure. Okay, so let's start out with the hepatitis C first, okay? So the liver is super duper important. Everything that you put in your mouth goes through the liver. Everything you eat, everything you drink, all your medications, everything goes through the liver, and all the blood goes through the liver. It takes everything that you put in your body, and it makes takes out the minerals, the vitamins, the energy. It also takes out the toxins. Everything that is a byproduct takes it out. If you have an infection, takes out the bacteria components, the toxin components out. Red blood cells, when they're all done, takes out the red blood cells. Okay, so it has a huge job, and it's involved in almost everything we put into our body. Okay, so liver cirrhosis is basically scarring of the liver. Okay, the three kind of main things that cause liver scarring are alcohol, too much alcohol, viral hepatitis, and we're talking about hepatitis C, and then fatty liver. So I was kind of looking up how much do you have to drink in order to start that, you know, cirrhotic process of the liver. And, you know, it's not that much. It's about, for women, about 3 to 4 drinks a day, up to about 10 years maybe. And then their liver, and sometimes a little sooner, maybe a little later, you can start getting liver scarring. For men, it's about maybe 4 to 5 drinks a day. And that turns this beautiful liver with all its, you know, clean, nice, fresh out of the crate kind of cells doing all its job and functioning, to this sort of bumpy looking, it kind of looks like a pepper steak to me. I don't know. Doesn't it look like a little bit of a pepper steak? But okay, so when that bumpy scar tissue replaces that healthy tissue, it's not doing the job. It no longer does a job. The blood's going through and all the nutrients and everything we put in the body is going through, but it's not able to do the job of getting the nutrients, making the vitamins, etc. So this one right here, that is a hepatitis C virus molecule, and then down there is a fatty liver tissue. The reason why we talk about hepatitis C is because in the population, in the general population, hepatitis C is kind of a sort of a low infection, but in our clients, it's very high because of their IV drug use. 73% of people who use IV drugs have hepatitis C. So that's a really high percentage. And about 20 of those folks will develop a cirrhosis of the liver. Okay, others, sexual contact, and the other ones there too. Okay, so what are the symptoms of cirrhosis of the liver? So this guy up in the left-hand corner there, he has jaundice. Okay, why? So as we said, the liver is scarred, it's not doing its job, so it can't get rid of bilirubin, which is a byproduct of red blood cells. And what happens is that's not going out, so it is absorbed in the skin and in the eyes. So they have yellow skin and itchy skin and very yellow eyes. That one in the upper left is an esophagus. That's a camera going into an esophagus. Okay, imagine the 405 freeway at probably any time of day. Okay, it's very crowded, it's congested. What do we do when we get on the 405 freeway and we look and see like miles of cars that are bumper to bumper ahead of us? We try to get off, right? Because we want to find a better way to get around that big, obstruction. So that's what's happening with the esophagus. The blood goes through the liver, but it's backed up. So the blood takes other pathways to get through the body. And one of those pathways are the veins in the esophagus. What happens to them? They can't handle all that blood flow and they become swollen and what's called esophageal varices. Okay, that's like varicose veins of your esophagus. And what can happen is they can get so big they can burst and a person can bleed and become really sick. So in the that side, the feet, that's edema, and again, same concept. The flow of the blood is not going through the liver in a fast enough way, and so that fluid has to go somewhere, and it can seep into the lower extremities. And then the belly, same thing. It goes into the peritoneal cavity. And with some of these patients, unfortunately, they get to that state, they need to have their bellies drained every 2 to 3 days, and that's really impactful to them, and that's very, very much an end-stage symptom. There is treatment for Hep C. It's expensive, and at DHS it's limited, although it's opening up a little bit more, which is great. We just got an email the other day that's saying they're opening up to different genotypes. They were doing just one genotype. There's different genotypes of hepatitis C, and so they're opening up to kind of include a little bit more of the genotype of hepatitis C, but it's expensive. And so the patients who get to go for treatment have to be a bit pristine, unfortunately. They have to not be using IV drugs. They have to be not drinking alcohol for 6 months. And so there's a lot of stipulations they put before us in order to treat them. So, and that's a little bit hard sometimes for our clients. And then, of course, the end game treatment is the liver transplant. Somebody told me the other day that one of their patients went in for a liver transplant, and you saw how big that liver was. It's a 3-pound organ, When they went in for the liver transplant, took out the old one, it was the size of a walnut. Yeah.
They were still alive.
Yes, very barely, yes. So, of course, there's other things that, our clients might imbibe in: alcohol use. They might have a co-infection of HIV. They might be eating a very fatty diet and have comorbidities such as other chronic diseases like congestive heart failure, etc., can make the cirrhosis worse and progress. Okay, so diabetes, very common. So many of our patients have diabetes. I mean, it's just amazing that something that tastes so good is so bad in your blood, right? So there's two types. There's insulin dependent, which is a type 1, and how that happens is a little bit unknown. There's some theories that it could be due to an infection, or it's an autoimmune syndrome. But basically, there's no insulin. The pancreas isn't producing insulin to take that, sugar into the cell. Okay, so basically, what it is the insulin couples with a glucose molecule and walks it over and pushes it into a cell. Okay, that's basically the easiest way I can describe that. So what's happening with the type 2 diabetic is that it's trying to escort it over, but that glucose cells, or the cell itself, is not having the glucose. It's not receiving it. It's intolerant to it, okay? So the type 2 diabetes is much more hereditary. Has to do with lifestyle. So that is kind of more something we can control a bit better. The type 1, they will always have to use insulin since they don't produce it. The type 2s can be on oral medications for a while, and if we can intervene and help them with diet, help them with exercise, they can stay on orals, but sometimes it progresses. And sometimes even a patient does all they can possibly do and they still progress to needing some insulin, and that's okay, All right, so the side effects of uncontrolled diabetes. The one in the upper left is a photo of the retina. So high glucose in the blood, the blood starts with big vessels and goes to small vessels and capillaries. Capillaries feed the retina. Capillary that gets high sugar breaks down. It's toxic to those very delicate capillaries. And so it breaks down, isn't able to give nutrient to the retina. The person loses the retinal function, and they can become blind. That upper right-hand corner there is a heart that has had a heart attack. The arrows show areas in the heart muscle that were obstructed and did not get the oxygen and nutrient to its muscle, and that muscle died, and that's a heart attack. In the bottom there, have any of you guys seen feet like that? You have, haven't you? Right? So these two are, they're the vessels were not able to feed the toes because they were damaged by the high sugar, and so those are going to need amputation. And then that middle one is a diabetic foot ulcer. Has anybody seen a diabetic foot ulcer before? They can get really, really bad and also become infected and cause a need for amputation as well. And then what happens though, why don't we get ulcers like that? We can step on something, we might feel it, but does it get that bad? No, because the high sugar prevents our folks from healing very easily. They don't heal as readily as we do if we don't have diabetes. And then this other condition here is called Charcot foot and ankle. And what that is the nerves become very, very damaged, and because of that, there's spontaneous fractures of the ankle and dislocations, and you can imagine it's so painful. They can't walk, they have problems with for ambulation, and this is like the cornerstone of good management is exercise, and they're kind of out of the game when they have something like that. And then lastly is that's a person getting dialysis. Diabetes can really hurt the kidneys, and then having to be connected to a dialysis machine every other day is pretty impactful to somebody's life. Okay, congestive heart failure. That's a nice, beautiful, healthy heart that looks really nice. Okay, so this is just easy, I'm going to just describe easy the blood flow through the body. So you have your inferior vena cava that drains all the blood from the lower part of your body, and you have your superior vena cava that drains all the blood from the upper part of your body. It all goes into the right atria. Goes from the right atria to the right ventricle. From the right ventricle, it goes out, it goes to the lungs that oxygenates that blood. It comes back through the left atria to the left ventricle and then out toward the body. That's the basic blood flow. So, normal heart looks good. That's a sagittal section of it. We have the muscle, looks very symmetrical, looks very nice. Okay, so the middle one is that heart muscle on the left ventricle looks a little bit big. What happens when you do weights? What happens to your bicep? Get bigger, stronger, feels good, it's awesome. When a heart has to work really hard, the muscle gets big too, but it's bad. We don't want that muscle getting big because what's happening is that muscle is having to work really hard to push blood through a vessel that's constricted or blocked, due to plaque, and it's working way too hard. So what happens after it's working so hard? It starts to become dilated. And so when you have a dilated left ventricle, it basically is a terrible pump. It can't pump very well anymore. So you're going to see a lot of the same stuff that you see with a liver, right? Because the blood flow is slow. It's slow and it's not going fast. So it's causing edema in the lower extremities, ascites in the belly. But with this, because the backup is also in the lungs, you're going to get a cough, you're going to get fluid in the lungs, you're going to have a person who's really fatigued because they don't have a lot of good oxygenated blood getting to where it needs to be in a timely manner. Okay? So it's kind of the culprit of congestive heart failure is poor diet, smoking, no exercise, high salt diet, hypertension. All those things that make the heart work really hard. So I want to just go through, and I actually did this at the ICMS, the quarterly meeting that last time we were all together, but this is so important in your job. I mean, I gave you some information about symptoms and that sort of thing and what to look at, and if you know that your client has hepatitis C and they start developing that stuff, you're going to kind of like, oh yeah, this is not a good thing, and I know what that probably is. But when you are with your patient, you're going to have, or with your client, you have a lot of deliverables, right? You have a lot of things that you are responsible for on your weekly, on the weekly basis, right? You have to say that you've done X, Y, and Z. I know on your weekly deliverables, there's not a lot of that you have to say that the patient had an appointment at this time and at that time. It doesn't get as detailed. But on a monthly basis, I'd like to challenge you of all your other challenges that you have is really connect. And it's going to give you just these 3 questions are going to give you so much information. Do they know where their clinic is? What's the address of that clinic? Who is their provider? This is stuff that it would be great for you to know as well. When was their last appointment and when's their next appointment? So I just want to tell you that when I know your role, but I know also my community, my provider community, and I know that providers want to help their patients. They really, really do. And sometimes I want to challenge you to go into an appointment with your client, but tell them what you do. Tell them why you're there. Sometimes we get people coming in the room, as long as your client says that's okay, but if they knew what you did, if they knew what you were trying to do, if they would be so behind you, they wouldn't give you a hassle when you're asking them to turn in paper and sign this. They're like, oh, I know that patient. That patient is in a Housing for Health program. I want to expedite their paperwork. They know. And I know that for a fact that the providers would be much more willing to help out if they know exactly what your role was. So I challenge you to go into appointment with your clients, tell them who you are and what you do. That's really important. Medications, make sure that you know where their pharmacy is. If they have 5 pills left, do they have refills? Are they going to go pick up their meds? Do a 5-pill rule with them. You got 5 pills, go get your refill. You don't have a refill, you know, call your doctor's office or tell the pharmacy. The pharmacy will fax us and we will sign it and send it off, okay? 5-pill rule for them. And also up by the medical provider, medical insurance. I know that's one of your deliverables, but try and get them into a managed care because it's really hard to get services, DME, all this stuff for clients unless they're in a managed care like HealthNet or LA Care. Straight Medi-Cal, it's very difficult. So if you can get them to choose and get a provider, that's really, really beneficial. And then mental health. Where is their clinic? Who is their provider? If they don't have a provider, do they need a provider? You know, do you all feel comfortable having those conversations with your clients about mental health? Pretty much. Okay. If you don't, you can ask their medical provider to have that conversation too.